pleasure. I haven't been out here before. It's a beautiful facility, so I appreciate you guys having me out here. How many of you all have dealt with dizziness or vertigo personally? How many of you know somebody who's dealt with it?
Oh, I'm on.
Yeah, so it is a very common thing. We see a lot of this in our practice as ear, nose, and throat doctors. So today we'll kind of delve into it and talk about what causes it and what we can do to fix it. I don't have any conflicts of interest to disclose. I like to start with some comics because laughter is really the best medicine, right? So this guy comes to his doctor, he says he's on top of the world, panicky and dizzy and nauseated. He's afraid of heights. Sometimes if you're feeling really good, it could be scary. This guy is saying he's there for dizziness, and his doctor's saying, here's something that should relieve those dizzy spells. Stop chasing your dadgum tail. Dizziness too. And then the last one, so you develop vertigo from your HMO giving you the runaround. This really applies more to me. I get this nowadays. So, but in all seriousness, dizziness is a really common symptom, and it's among the most common things that takes people to their doctor or to the emergency room. And I call it a diagnostic and therapeutic challenge, meaning it can be difficult to figure out what's causing it, and it can be difficult at times to treat it. There are completely benign things that can masquerade as life-threatening problems, and then vice versa as well. And we know that chronic dizziness and vertigo can really have a negative impact on our quality of life, and so it's important that if it is there, that we try to do things to treat it. So my goals for today is for all of us to be able to give an accurate description of what dizzy is, because it can mean a lot of different things, and then distinguish what is truly an inner ear problem versus other causes of dizziness. And then finally, we'll talk more about this, understand what the role of balance testing is in something called vestibular rehabilitation therapy. We'll talk about these more. So this is a case that I saw in the hospital probably about 6 months ago, not atypical. It was a 55-year-old gentleman. He had high blood pressure, high cholesterol, and he came to the ER complaining of just severe room-spinning vertigo that started about an hour before he got to the hospital. And he said that whenever he moved his head, he gets really sick and nauseated, and he had actually vomited a couple of times. And so a lot of different things can be going on here. Is he having a stroke? Is it an inner ear thing? Is he dehydrated? So we'll revisit this at the end and kind of put this all back together and figure out what's going on with him. So we'll talk about the anatomy of the ear. We'll talk about the types of dizziness. We'll talk about how we evaluate and assess dizziness. And then we'll talk about the different types of inner ear pathologies. And there are 3 that we'll talk about. And we'll go over each of those in detail. One is called positional vertigo. There's one called Meniere's. And there's another one called vestibular neuritis. And then we'll go back to our case. So the ear has 3 parts. The outer ear, the middle ear, the inner ear. The outer ear is basically just what we can see and touch out here, the pinna or the auricle. The middle ear is behind the eardrum. That's where the tiny little hearing bones are. And then the inner ear, which has the hearing organs and the balance organs. And so this is all shown here. So the outer ear shown here, the middle ear right there with the tiny little hearing bones, and then here's the inner ear, the hearing organ, the balance organs. And basically, the inner ear detects our body movement relative to gravity. And what our inner ear does is it tells our brain where our head is moving, if we're moving forward, if we're moving backward, up, down. And then basically it helps our brain tell us how we need to adjust our vision and our posture to stay upright and to keep a good steady balance. And this is just a detailed picture of the inner ear. It's very intricate and it's kind of beautiful if you think about it. This is a tiny little structure in our head. It's really no bigger than about a couple of centimeters. And this little snail-looking thing is the hearing part. And then these little canals here, these semicircles, those are the balance organs. And so they send all this information to our brain through these tiny little nerves here. And so really the inner ear is what we as ear kind of focus on. And just to understand kind of what the inner ear does, I don't want to get too technical, but a little bit of background helps. There's what's called the vestibulo-ocular reflex, and that sounds really complicated. But basically all it is when we move our head, our eyes move the other way to maintain an image. So if I'm looking at you and I turn my head, my eyes have to go that way even though my head is going that way. The same thing goes for the other way. The inner ear is what's making that happen. And so that's something that we use a lot of when we're trying to assess the inner ear. And again, it just stabilizes an image in our vision as we move our head. And there's another reflex called the vestibulospinal reflex. And this is the reflex that comes up from our legs and our feet that helps us maintain an upright posture. We'll talk more about these. So when I think of the balance system, the brain gets three sources of information, okay? One is what we call vestibular. That's our code word for inner ear. And then there's the visual system, which is our eyes. Obviously, that's critically important. And then this bottom one called proprioceptive, or the touch, which again is your legs and your feet and how they feel on the ground. And then basically the brain integrates all of this, puts it all together, and then, again, affects our eye movement, the movement of our legs and feet, to keep us upright and moving forward and not swaying and things like that. So that's kind of the basics of how our balance system works. So when I see somebody with dizziness, or if somebody comes to us to ask, they're having dizziness or vertigo, the most important thing is just sitting down and talking. And usually within about 5 to 10 minutes, just from asking quite the right questions, you can figure out what the cause of the dizziness is. We definitely incorporate a physical exam to kind of augment that and help confirm what we think. And then sometimes we use specialized testing or imaging to, again, either confirm what we're thinking, or if we're not sure what's going on, it can help us kind of figure it out. So when I say history, I want to know, when did it start? What does it feel like? Describe how it actually feels. How long did it last? Is it all the time? Does it come and go? How bad is it? Did you really feel like you just couldn't move at all, or was it just a vague lightheadedness? And does anything make it worse, or does anything trigger it? Does anything make it come on? And then, are there any other symptoms? Like, do you feel weak on one side of your body, or do you have trouble talking, or do you notice that you get ringing in your ears? Things like that. Any other symptoms can kind of help us target what the cause might be. And so again, to just define things, when I say vertigo, or when a medical professional says vertigo, we're talking about the sensation that the room is spinning around you. Almost like somebody said when they were in college and they had too much to drink. That's kind of what the feeling is like. It's the sensation that things are moving when they're not. There's this other word called pre-syncope, and we use that to describe, people say they felt like they were going to black out, pass out, fall out, get lightheaded. We use the word pre-syncope. Then we have disequilibrium, which somebody just says, my equilibrium feels off. I feel kind of wobbly, I feel shaky, or off balance. And then there's lightheadedness again, where you just feel like you're almost out of your own body, like you're having an out-of-body experience, or you're seeing yourself from above, something like that. So these are all the descriptions that we try to really pin it down so we can get an idea of what is really the cause of the dizziness. So again, with the pre-syncope, this happens a lot of times when people go from laying to sitting or sitting to standing. And basically, medications or blood pressure can be the cause of it. You stand up and the blood pressure drops and you get lightheaded, like you almost pass out. Sometimes if you have an abnormal cardiac rhythm, like atrial fibrillation or AFib, that can cause that too. And then narrowing of the carotid arteries. Some of you may have had an ultrasound of your carotid arteries to look and make sure they're not too narrow. So there's a bunch of medications on here. I won't go through all of them individually, but as a group, cardiac medicines can cause it. Other what we call central nervous system medicine, so pain medications, anxiety medications, muscle relaxants, antidepressants. And then urologic medicines, Viagra, Levitra, Cialis, and then medicines like Flomax for the prostate can also do that. So any of these medicines can give you the sensation that you're lightheaded when you change position. So I tell people when you're changing position, you got to go really slow. When you go from lying to sitting, take a couple seconds sitting to standing, give yourself a few seconds before you're up and about. The disequilibrium, again, is more about off balance or wobbly sensation. And this basically is just an inability to stay upright and walk in a straight line. It may be caused by poor vision or peripheral neuropathy. You may have heard, you ever heard people get burning and tingling in their legs or feet from diabetes or from chemotherapy. That's what peripheral neuropathy is, and that can cause that as well. And then neurologic disorders like Parkinson's can obviously affect our ability to kind of walk in a straight line. And then lastly, back to the lightheadedness. Again, these are always kind of vague symptoms. Classically, they say hyperventilation. Hyperventilation is just breathing really fast, really deep, really fast. If somebody breathes really fast, really deep, they're going to get lightheaded and they may even pass out. But other things like panic attacks, anxiety can also give these same symptoms. So that's kind of the history. Now we're going to talk about how we evaluate, what is our exam? How are we going to examine a patient with dizziness? And in many cases, our physical exam, looking in your ears and your mouth, and it's all totally normal. So we have to do other exams to try to figure out exactly what's going on with the inner ear. And there's a couple of tricks that we can look for and do that will give us clues. And we'll talk about each of these individually. One is called nystagmus, one is called a Romberg test, and the other one is called Acute. And we'll talk about each one of these individually. So spontaneous nystagmus it's an abnormal eye movement that basically causes the eyes to drift very slowly to one side and quickly jerk back to the other side. And it's a very characteristic eye movement. And it basically results from usually a weakness in the inner ear on one side. And so we got a video here just so that I can kind of show you what this looks like. See if we can get this to play here for us. There we go. So this is a person who has nystagmus, and you can see that the eyes are kind of drifting slowly off to the right, and then there's a quick jerk to bring them back towards the center. And this is a very abnormal finding. So if somebody has a finding like this, then we're usually thinking that there's something going on either with the inner ear or with the brain. But it is a very characteristic movement of the eyes that when you see it, you can't miss it. The next test is called a Romberg test, and this is pretty easy. We have patients just kind of stand with their feet together and their arms crossed like this, and we basically just have you close your eyes and see if you can maintain an upright posture kind of with your eyes closed. We call it positive if you kind of fall or step off to the side. So again, these videos kind of help show here. This is what a normal Romberg test would look like. A little bit of sway is okay, and that's not entirely abnormal. An abnormal test would look something like this. See, the patient really just can't even maintain their posture. They just fall to one side or the other. So that, if we see that, that is an indication that there may be an inner ear problem or a problem with the legs or the feet. And then the last one is called Acute stepping. And we have patients just put their arms out in front of their body, close their eyes, and just march in place. I tell people, just imagine that you're in a marching band and you just want to march in place. And if you deviate to one side or the other, that suggests potentially a problem with the inner ear. And so, again, here's kind of what a normal situation would look like. And we kind of have these lines here to just kind of keep an idea of how far somebody is drifting. But that would be normal, and we would just keep going like that. And then here's somebody that would be abnormal. So you can see he's kind of drifting to the left side. And when somebody's doing this, they don't realize that they're doing it. They think they're actually just marching in place, looking straight ahead. When in reality, they're kind of going, like this. And so this is a really good test for me to help clue in, is there potentially an inner ear problem going on? And so if we think there is an inner ear problem going on, we might recommend what is called a balance test, which is a battery of tests we do in our office, here in Franklin and downtown. And it is basically, it's an objective way to test the inner ear. It puts it into a number, it quantifies it. And it can tell us if one of the ears is weak, and if it is weak, how weak is it? So this is a big long word, I can barely even say this word. It's called a video nystagmography. And we use these special goggles to kind of track the eye movements. It sounds kind of barbaric, but we irrigate the ears with water, we shoot water into the ears, and that tricks the brain into thinking the head is moving. And that causes the eyes to move in certain ways that we can then track. And this is kind of what it looks like here. So there's a young guy sitting in the chair with the special goggles on. In this chair we kind of spin people around and we see what the eyes do. And then here's some more testing by one of our audiologists, again, doing this balance function testing. And this is a way that can really help us figure out what is going on with the inner ear. So that's kind of how we assess, dizziness. And then let's talk about what the causes are, okay? So there's three main types of vertigo that we'll talk about. One is recurrent positional vertigo, meaning that you go into a certain position and you get vertigo. And it doesn't last very long and then it goes away. Then there's what I call recurrent vertigo attacks, where attacks just seem to come on out of the clear blue sky. You're not doing anything, you're not in any position, they just happen. And they happen over and over again. And then the last category is what I would call severe acute vertigo. Kind of like the gentleman at the very beginning of the presentation, our case, who's never really had vertigo before, but then all of a sudden just gets it really bad out of nowhere. So the first one, the recurrent positional vertigo, typically the symptoms are triggered by a certain head movement. If you, lay your head back, or you're at the grocery and you look up, you might get a sensation that the room is spinning. And typically, patients will come to me and they'll say these episodes really scare me, but in between I feel pretty normal. I feel fine right now. But when I move my head a certain way, I get really bad dizziness or vertigo. And the diagnosis here is called benign paroxysmal positional vertigo. And if you've ever heard anybody talk about crystals or stones in the ear, that's what this is. So if somebody said they had crystals loose or they had rocks in their ear that were loose, that's what this is. And so, to make a complicated thing simple, it's really just these tiny little crystals in our inner ear that get dislodged, either for no reason or sometimes after bumping your head or a car accident or something like that. And so basically what happens is you get these vertigo spells that usually only are about a minute, maybe a minute or two. They don't last very long. Normal in between the episodes. And then again, the classic people tell me they rolled over in bed and then the world started spinning, or they looked up and everything started spinning. So the way that we assess this, again, the exam's going to be normal, we do what's called a Dix-Hallpike test. And basically all it is we just have you starting in a sitting position, and then we just lay your head back and turn it to one side or the other, and we see if you get dizzy. It's a very easy test to do. And so this is kind of it depicted. Your doctor will lay you back with your head turned to the right side and see what happens, and then do the same thing on the left side. And what we're looking for, we talked about that nystagmus, that eye movement earlier. That's what we're looking for. We're looking for that characteristic eye movement, which is a little bit different than the one I showed you earlier. But when we lay somebody back with who has the crystals loose, their eyes will start jumping out of their head. And you can see it's a pretty violent jerking of the eyes. And during this period, the patient will feel very dizzy. They will feel very dizzy. I've had people kind of scream and get real scared, but it always fatigues, meaning it always goes away after about 20 to 30 seconds. And the treatment of this is what's called an epilepsy. And it is basically, we just, it sounds kind of like voodoo. We're going to turn your head in certain ways and it's going to fix the problem, but it does. We start you on the bad side with the head hanging there. So the bad side for this person would be the right side. And then we go to the left. And then we roll you up on your side and point the head down. And what that does is it gets these stones to go back into the place where they should be. And it is a highly effective maneuver to treat this positional vertigo. And I'll show you this video here because this kind of shows, try to get a little bit of sound here too. So you see her eyes just jumping and jumping and jumping, and you can hear her, she's very dizzy. After about 30 seconds, it really starts to slow down. So he started on her bad side, which was the left side, and then he waited till it went away, then he turned her to the right. And she got a little bit of the same, jerking eye movement there. We're going to kind of skip ahead for the sake of time here. And what he'll basically do is kind of roll her up here and turn her on her side, which you can see here. So she's rolled up onto the side with the head pointing down there. And we stay in each of these positions for about a minute or 30 seconds past when the dizziness stops. And so then he kind of sits her back up. And the great thing is that after doing this, he lays her back again, and she has no symptoms at all. So in other words, before the procedure, he laid her back and she was dizzy, the world was spinning. You do this maneuver, and he lays her back again, and the dizziness is completely gone. This is probably my favorite type of vertigo or dizziness to see because we can fix it so easily. Now sometimes it takes a couple of rounds of doing that in the office, so I have people come back every 1 to 2 weeks for a few visits just to make sure that we've got it completely resolved. But this is the type of vertigo that we can fix in the office very easily, which again is wonderful. So we'll leave that behind, and then we'll go to the next class, which are called the recurrent vertigo attacks. People come to me either right after an attack, sometimes they end up in the ER for the attack, and then they get sent to me. But again, with these, there are no provoking factors, meaning there's nothing that seems to trigger an episode. It's not, oh, I turned my head a certain way and I got dizzy. The episodes just seem to come out of nowhere. And the most common thing that we see with these, one of the more common things is Meniere's disease, and we'll talk more about that. The other thing that we see is what's called a transient ischemic attack, which is kind of like a mini stroke or a brief stroke. But Meniere's disease is a very poorly understood disease, but we think it is from too much fluid on the inner ear. So here's what a normal inner ear looks like. Here's what an abnormal inner ear looks like with Meniere's. And basically, there's too much fluid on the inner ear. That causes abnormal sounds in the ear. It causes ringing or roaring in the ear, and then causes these attacks of vertigo. So the classic person with Meniere's will come in and tell me, Doc, I get these episodes where my ear starts feeling really full, and then it starts ringing, and my hearing goes out, and then the world starts spinning. And that lasts for 4 or 5 hours. And then after that, I feel like I need to go lay down for a little while, and then the next day, I feel okay. It's not uncommon to get sick. You get a lot of nausea, vomiting even at times with these episodes. So that's the classic story for a person with a Meniere's. Now, how we treat it, for somebody that's having an attack, we give them medicines like Valium or a medicine like Meclizine, which you may have heard of, and then medicines to control the nausea. For some, what we call maintenance therapy, the best thing we can do for people with Meniere's is to try to find ways to prevent these attacks, because there is no known cure. We can't cure it, but we can minimize the frequency and the severity of these attacks. And so the two things that are very effective, low salt, low caffeine diet. So I ask people to get really low on their salt intake and cut out caffeine. And then the last thing is an oral diuretic, a water pill essentially, to get that excess water off of the inner ear. And that can really help patients. There are more advanced treatments if those things don't work. One of the newer things that we do is an injection of a steroid into the ear, which sounds terribly painful, but it's really not that bad. We do it in the office. And then there are surgical therapies, but those are extremely rare and really reserved for when everything else fails. This is a picture, a cartoon of how we do the injection in the office. And again, I know it looks horrible. There's a needle going into the ear, and you probably think, gosh, that looks very painful. But we're able to get the eardrum very numb, and then we're able to get the steroid medicine into this space, and then it goes into the inner ear. And in a lot of people, it can really help their Meniere's. There's also other inner ear pathology, what I would call a vestibular migraine. You've heard of migraines. This is kind of like a headache, but instead of getting a headache, you get dizzy. And sometimes there's also bright lights tend to be bothersome, or loud sounds tend to be bothersome. So when we get the dizziness and those symptoms, we start to think about vestibular or inner ear migraine, and usually that's when I get the neurologists involved to use medication to help treat that. And then there's the TIA, which, like I said, is like a mini stroke. Usually this happens and there's no ringing in the ears, no hearing loss or anything like that. And this is something that probably people would end up in the emergency room and have to get a CAT scan or an MRI. So the last type of vertigo we're going to talk about is the person who has a severe attack of vertigo who's never had that before. It's just a one-time thing. It comes on very suddenly with no prior history, a lot of nausea, upset stomach. And the things that we worry about, the two things, one is called vestibular neuritis, and we're going to talk about that in detail, and then the other one is a stroke. And that's scary because it can be really hard to distinguish those two. You know, one is really life-threatening. The other one is, you know, not as life-threatening, but it can be very debilitating. So what vestibular neuritis is, again, it sounds complicated. It's a dysfunction of the inner ear on one side that we think is related to a virus. How many of y'all have heard of Bell's palsy? Have you ever heard of Bell's palsy? You know, you had it? Yeah, so Bell's palsy is where your face just goes weak for no apparent reason. Your face just is paralyzed. And it usually gets better on its own and it goes away over time. And we don't really know what causes that. It's kind of like the same thing. The inner ear on one side becomes paralyzed. And again, you get all of these symptoms, and we got a little bit of a typo here, but basically patients just come in with really bad room spinning. They can't move their head, they want to keep their eyes closed and just kind of have a dark room and not move their head at all, because if they move their head, they get really sick. So in the early stages of this, we'll see that nystagmus, that jerking eye movement that we showed you earlier. And they will also have abnormal Romberg and Fukuda tests. So those tests that we showed earlier, those will be abnormal. The treatment, once we've diagnosed with somebody with this, the best treatment is steroids, believe it or not, prednisone. And we give that a taper over about 2 or 3 weeks. If somebody has diabetes, I usually avoid giving steroids because it can make the blood sugar go up really high, and we try to avoid that. Antiviral medicines have not really shown to be helpful, and so I tend to avoid those. And then a lot of times in the ER they'll give meclizine or something like that, and those are okay initially, but in the long term I try to get patients off of those. And the best thing for people who have an episode of this is the vestibular rehabilitation, which we talked about and I mentioned earlier. And basically what that is, it's a way to address an inner ear problem. And we know that these inner ear problems, they can have a really profound impact on all of our daily aspects of life. And the evidence for vestibular rehab has shown that it's effective in improving symptoms related to inner ear imbalance problems. So basically what it is, it's a specialized form of physical therapy that not just any physical therapist can do. Only ones that have a specialized training in vestibular therapy can do it. And it is a kind of exercise-based program. It's designed to reduce vertigo and dizziness, gaze instability, where you feel like your eyes are kind of moving around, and then reduce the risk of falls, which is obviously really important. And in most cases, we have people do it on an outpatient basis, meaning they go to the facility where it's done, they do that a few times a week, and then they transition to like a home program. And so the therapist will teach you a program and then you can do yourself with some assistance. And so the outcomes, what we would expect people to get after going through vestibular rehabilitation, a decrease in their fall risk, a decrease in their dizziness, better balance and posture, increased body strength, improved ability to stabilize the vision and the gaze, increasing confidence to maintain balance. I see so many people who tell me they just have lost they're scared. They're scared that they're going to fall, and they've lost their confidence on their feet. And this can really, really help bring back some of that. So to go back to our case, we went over the details of it. His exam otherwise was really pretty normal. He didn't have any weakness in his wrist.
So just keep looking straight at that red light. Just look there. Yeah, that's great. Now what I want you to do is look to the right.
It actually gets better when he looks to the right. To the left, it's a lot worse. So that was a really important exam finding that suggested that this was an inner ear problem. Now this patient actually had a big workup, which was appropriate because they were concerned about the possibility of a stroke. An MRI scan was normal, a CAT scan was normal. He also had an echocardiogram of his heart, he had an electrocardiogram of his heart, and all those were normal. He was admitted to the hospital and basically just given IV fluids, medicines for the nausea, and eventually he got better and he went home 2 days later. He then came to see me, and basically with the story and his exam findings, we diagnosed him with this vestibular neuritis, this weakness of the inner ear. And we did this VG, this balance testing, which confirmed it. And so basically we got him into vestibular therapy, and he did 6 weeks of that, and then continued it at home on his own. And at about the 3-month mark, he felt like he was back to himself. It can be a really tough recovery. Some people it takes 6 months to a year to kind of get back to feeling normal. But we know that this vestibular therapy is really important. So just to close, the final thoughts, the take-home messages, not all dizziness and vertigo is inner ear, okay? I tell everybody, one of the first things I do with folks is to review the medications, because many times medications can be what's causing symptoms of dizziness, so we always kind of start there. Vertigo is a room-spinning sensation, and if you have a room-spinning sensation, it is very likely that it is an inner ear problem. Most of the causes of vertigo are benign and can be treated by your PCP or more commonly an ear, nose, and throat doctor. The balance testing is a really good test that we do in our office that can help us figure out what's going on with the inner ear if we're not able to based on our exam in the store. And then for people who have chronic dizziness, chronic balance problems, the vestibular rehab therapy has really been shown to improve quality of life and decrease the risk of falls. So we end up referring a lot of patients for this vestibular rehab therapy. So this is just our team here in Williamson County. My partners, John Seibert, he was the first one with our Vanderbilt group down here about 8 years ago. I've been in the practice now for 4 years, and we just added a new physician, Daniel Schuster, who's out of his training. So we treat all problems of the ear, nose, and throat. We do surgery of the ear, nose, and throat, and kind of treat the whole spectrum from infants, the whole spectrum of life. One day I saw a 1-month-old and a 99-year-old in the same day. So we treat the whole spectrum of life. And we are not far from where you are. So here we are here in the Fountains. Here's I-65, and here we are right down the street on Highway 96. Google says it's 6 minutes to get there. If you want to walk, it's 46 minutes. I wouldn't recommend that in the heat. But that's really all I have. If you guys have any questions, I would be absolutely happy to take them. Yes?
I have experienced like baby rattles in my ears. Is that anything significant?
A rattling noise in the ear could be many different things. It could be fluid behind your eardrum. It could be rain or tinnitus. Does it rain or is it just like a fluttering sensation? Flutter. The other thing it could be, believe it or not, is wax. I've seen people with wax build up deep in the ear, and when that wax kind of expands, it can create a little bit of fluttering noise or crackling in the ear as well. So an easy way to assess that would be to have somebody look at your ears and see what they look like.
And I've been told my balance isn't the greatest.
Okay.
And I have therapy on my leg and back. And
Yeah.
he tried to help me to get my balance better.
Yeah. So a lot of times, again, if you have, rehab, physical therapy for, say, an orthopedic problem, a knee or a hip or a foot, is important, but it's different than balance therapy. And so if there is a balance problem, that's when, like I said, we usually would have you do a balance test, see what the status of the inner ear is, and then have you work with a vestibular therapist to really focus on the balance by itself. Yeah. Yes, sir.
I noticed in one case you mentioned salt and coffee.
Yes.
Is there any other substance, aside from medications, that can give you a problem?
Well, with that particular one, that was with the Meniere's disease. So people with Meniere's are more sensitive to salt and caffeine and even alcohol, than others. So those are the main things for the Meniere's disease. But yes, I mean, as far as dizziness in general, lots of medicines, but not really anything else that I would think of as far as dietary or lifestyle.
Dietary.
Yeah, dietary, no. Those are the main things, salt and caffeine. Yes, sir.
I can tell you, I went through that process that you explained.
Yes.
And I went to Dr. from Vanderbilt down here in Brothers, and I
Yes.
It's not fun to do.
Yes, the
When
therapy.
you feel that way, and then you gotta go through it all, but it does have to work.
Yeah. Did you do a lot of turning your head and
Yes.
looking in certain directions? And,
Exactly, all of
Yeah.
the things that you described is exactly what we did.
yeah. The
And
therapy
it
is
does help.
the therapy is challenging, and basically what they're doing is they're putting you in those positions that make you want to get dizzy, and that trains your brain over time to basically compensate for that. But that's really great to hear that you went through it and that it helped.
It did. And I'm a big coffee drinker, but I don't know if that has anything to do with it.
Probably not. Don't give up your